Good evening, everybody. It's good to see so many of you have given your time to join us this evening, and I'd like to thank our panel also for joining us. We have Ella with us from Leukaemia Care, who looks after our policy and public affairs, and Professor Alex Richter and Dr. Helen Parry from the Queen Elizabeth Hospital and from Birmingham University are also with us and will be joining us fairly soon. As soon as you can turn your cameras now on, guys. As I touched on with everybody, thank you for joining us. Today's webinar really is sort of a few purposes: to give updates on the current booster program, its importance, its significance, and the impact of boosters, and to look at treatments today of COVID, how they use their impact of the treatments, current and future, and what we know about COVID today, the changing environment, and we have our experts to answer many of your questions, which we've already collected in advance of today's webinar. But as I touched on earlier, please do post your questions into chat, and hopefully we can't guarantee we can ask all of them, but we will collect questions and be able to feedback as well after the event if we don't cover those. So in terms of the order of events today, the webinar will do a round of introductions in a second, and everybody can introduce themselves to you. So thank you again for joining us in the evening. It's looking out my window, it's not a very pleasant evening, so it's probably a good time to join us today. So we'll start off with some introductions, and then Professor Alex Richter will give a broad overview talk of immunology and what we know today about COVID and many of the issues to help you with your understanding and navigating. And then Dr. Helen Parry will look at some more specific data that's disease related. And I know many of you in the audience are CLL patients, and there is some focus there on some CLL specific data in terms of latest information about vaccine responses and outcomes and impacts of treatments. So without further ado, perhaps I could hand over first to you, Alex, to introduce yourself, and then if you could hand over to Helen and Helen to Ella, and then you can start your talk.
Oh, thank you very much. It's wonderful to be here today with you all. My name's Alex Richter. I am a professor of clinical immunology. So my day job is looking after patients who have an immune deficiency. And many of those patients are leukemia patients, because we know that leukemia itself can cause an immune deficiency, but also the treatments needed for CLL and different types of leukemias can cause an immune deficiency. So that's what I do in my day job. And then I also do a lot of research around a number of aspects of immune deficiency, trying to understand the immune system in patients with immune defects and how we might improve that and reduce the risk of infection.
Over to you, Helen.
Yep. So hi everyone, my name is Helen Parry and I am a haematology consultant at the Queen Elizabeth Hospital. So I work quite a lot with Alex, and I also do research at the University of Birmingham. So my sort of clinical area is particularly looking after patients with chronic lymphocytic leukemia, and my research sort of reflects this. But we've had for several years now at Birmingham quite an interest in looking at vaccine responses and immunity in patients with blood cancers. And this really predated COVID, but COVID has sort of accelerated everything a lot really and brought it all to the attention of everybody, which we're quite pleased about, because obviously it means that we're going to make further progress and speed that progress up. So hopefully I can share our latest data with you shortly.
Over to you, Ella.
Thank you. Yeah, so I'm Ella. I'm the Policy and Public Affairs Officer here at Leukaemia Care. So joining today to try and provide some of the policy issues and sort of guidelines where necessary. But I just wanted to say, if you did have any kind of individual questions or issues, things that you're struggling with, please do feel free to contact our advocacy service. So the email address for that, I'll pop it in the chat as well so you can see it. But yeah, I'll try and not answer specific questions, but I'll do my best to provide policy and guidelines where I can.
Thank you, Ella. And I'll introduce myself. To those who haven't met me before, I'm Nick. I'm also a blood cancer patient, and I work in the advocacy department for Leukaemia Care as healthcare liaison officer. And thank you to our healthcare professionals who I've reached out to help us today. So I think just wanted to mention to everybody, I've seen a lot of questions there about different types of blood cancer. The purpose of today is to try and have a broad brush approach looking at across the different blood cancers, and where possible, our experts might be able to make comments about the different blood cancers. This isn't one that's going to focus specifically on one blood cancer, although Helen may have some more specific information, a little bit more information about CLL. So just to put your minds at rest, we will come to your questions if we can. So perhaps, Alex, if you can, if you'd like to share your screen and commence your talk. Thank you.
There we go. Can we see all the slides?
We can.
Lovely. Thanks, Nick. Well, just what you've been saying, Nick, about individual leukemias and how they differ. What I do as an immunologist is look after patients with quite a broad spectrum of immune defects, and it is very much a continuum. And often there isn't, the actual leukemia isn't necessarily specific, but it is where you are on that journey or how that leukemia has affected you. And so I kind of look at the immune system as a whole, and this first approach would be very much at looking at kind of blood cancer and immune deficiency in the round. Now, I remember right back at the beginning in kind of March of 2020, I set up a registry between all the immunologists in the UK. And what we wanted to know was whether COVID, how it was going to affect our patients. Because if you remember those first patients coming on the intensive care unit, there was this really extreme immune response, and people were, it was very inflammatory. And so there was a theory at the beginning that in fact, our immune deficiency patients might be protected against very, very severe disease. So we set this, this registry up. And as I expected, it probably turned out to be the opposite. And most patients, in my experience, with some type of immune deficiency, doesn't matter how it is generated, whether it's a genetic defect or whether it's as a result of a blood cancer, means people are more at risk of infection and severe infection, which means hospitalisation and unfortunately death. And we reported quite early on that, in fact, for immune deficiency patients, that this was the case. But actually, things have moved on enormously since that kind of shock and awe and lockdowns. And, you know, what is the reason for that? And we're just trying to get our data together at the moment. And we're just about to try and publish this. But this is data from our registry. And if you look on the right-hand side at the 2020 UK cohort, we found that the inpatient mortality, so if you're admitted to hospital with a primary immune deficiency due to a genetic defect or a secondary immune deficiency, secondary to something else like blood cancers, your inpatient mortality was really quite high. So you can see for secondary immune deficiency, you know, 44% of people, if they were coming into hospital, were dying. Now, some of that is skewed because at that point we were only admitting the most sick. But it was still, compared to the general population, our immune deficiency patients were very, very vulnerable. Now, we've just repeated this exercise with the Omicron wave over winter. And if you look at something called the IFR, which is the infection fatality rate, it's dropped from 33% all the way down to 9%. So if you get COVID infection, the chances of it having a bad outcome is massively reduced. But what this still shows, that if you're sick enough to come into hospital, you really are still quite poorly. And we are very mindful of that with acute treatments at the moment. So the best thing is to keep most patients out of hospital. And actually, to some extent, we're doing this, and it's much, much better. Hospitalisation rates in the UK have dramatically fallen over the last year. And we've been looking through an immune deficiency study called COVID, which I've been running with Dr. Burns down in London and Dr. Shields up here in Birmingham. And we've been looking at infections and hospitalisation trends in our immune deficiency patients, you know, from the Delta wave, which was January 21, through to the current wave now. And if you look at the box on the left-hand side and you take that down as well, in those early months of January, February, March, April, you can see the red bars are higher than the blue bars. And what that's saying is that the general population were actually much more likely to be admitted than our immune deficiency patients. So when we talked about this and we thought about it, the key difference here was that shielding was making a real difference, and our patients were really quite good at shielding. So this started to give us some evidence that, you know, that actually that social distancing is a valuable tool in our trade. So, you know, there's been a lot of discussion around social distancing and wearing masks and all those preventative measures. But I think it does, well, I think there's increasing evidence that did make a difference. Now, if you look at the more recent wave, and actually if you look from late Delta, so from when social distancing, when we got rid of it last summer, think about football and the Euros, actually, can you see the bars change? And we've now got more blues than we do reds. So suddenly, the shift and the burden of COVID on hospitals is not coming from the general population. It's coming from our immune deficiency patients. And this highlights to me that as a group of people, immune deficiency patients, regardless of the immune deficiency, remain vulnerable to hospitalisation. So I guess I'm talking to a converted audience. COVID's not over, is it? COVID is not a common cold. People with common colds don't get admitted to hospital at this rate. So what we've got to work out now is who is at risk, what we can do about that risk, and what options there are available to us. But I wanted to start with this really good news story that actually things are much, much better in terms of hospitalizations and death from COVID in just the last 12 months. So where has this improvement come from? Now, the three key things that I think we need to talk about are vaccines, and Helen's going to give a lot more detail on vaccines. But I'm sure a lot of you will be shouting at me at the moment saying, but what if you don't respond to vaccination? And I agree with you. And I think when it comes to vaccine responses, we also want to know how good that response is. And just have a little think about, is some response to vaccination better than no response? So Helen alluded to the fact that she and I have done quite a lot of work prior to COVID on vaccination, and we've looked at responses to flu vaccines, pneumococcal vaccines, all those things that cause infections in immune deficiency patients. And actually response to all those vaccines is less good than healthy individuals on the whole. And it's kind of, you know, we need to remember that COVID is just one of the infections that immune deficiency patients are vulnerable to. Now, the huge advantage we've had over the last year as well is these treatments that are coming. We started with acute treatments in hospital, and I'll talk about a little bit more about these. And we're now moving to kind of outpatient early treatments. And we're all hoping that this is then going to head towards what we call pre-exposure prophylaxis. So giving people preventative treatments like a vaccine, but just in a form of a medicine. Now, the other theory about improved outcomes is that it's a milder virus. And maybe there is some evidence it is slightly less severe, but if you look at populations that have either not been vaccinated or been vaccinated with suboptimal vaccines, mortality rates have been really high with Omicron. And I'm sure you saw there was news around them running out of coffins in Hong Kong and awfulness like that. So I don't underestimate Omicron. But I think that what is making the difference is we have vaccination and we're having these acute treatments. So when we look across immune deficiency patients as a whole, we found that 61% made some antibody and T-cell response to vaccination. And I have to say, as immunologists, we nearly fell off our perch at this point. This was such amazing news because every single one of these patients, by definition, will have failed to respond to the pneumonia vaccine. That's how they've been selected. So what we're dealing with is a really strong vaccine that is able to produce an immune response in people that don't respond to other vaccines. So, I mean, that was incredibly exciting news last summer when that first came out. It's way above our expectations. And then the government brought in the third primary dose. And the logic here was that although immune deficiency patients, some of them could respond, there is a lot that can't respond, so, you know, nearly 40%. But if I could just ask you to have a look at my slides, if you look at the healthy controls on the right, so if you just look at the grey bars and you look at the post-V2, so this is post-vaccine 2 in the healthy controls, can you see that that line is much higher than the immune deficiency patients from our COVID study? So although we've got patients making an antibody response, actually on the whole, the level of that response is less. Now, so what? Does that matter? Well, we don't really know whether it matters because we don't have what we call a correlate of protection. We have not found an antibody level or a T-cell level that confirms that either you would be protected against all infection, which we call sterilizing immunity, or whether it just protects you from having severe disease and dying. And we call that protective immunity. And I think because of the complexity of people and their immune status, because of the complexity of exposure to vaccines and natural infection, because of different variants and treatment options, that finding a correlate of protection has not been possible, despite huge global efforts to try and identify one. So when you say to me, is that a good antibody response? Or, you know, what level do I need? It's very difficult. And in very broad terms, what I say to my patients is, it's better to have some than none. And it's probably better to have lots than some. But actually, the detail on that is not there. So what then happened when we gave a third primary dose? Well, we were delighted that actually the level of antibody went up significantly from post the second vaccine to post the third vaccine. So you were getting an additive booster effect. So not only were more people in our study protected, but they also had higher antibody levels and higher T-cell levels. Now listen, there's still, what, 76, so 34% of 24% of people that we could make no antibody response with. And that tells us that those are probably the most vulnerable individuals in our group of patients. And then just trying to have a little think about what I said to you before about, is some antibodies better than no antibodies? We've looked at our national cohort and we've split it into patients who made no antibody response and made some antibody response. And then what we've done is looked at what's happened to them over the Omicron wave since they've been in our study. And what we found is actually most immune deficiency patients remain symptomatic with Omicron. So, you know, it's not just a mild asymptomatic infection. So, you know, in both the no antibody response group and the antibody response group, you know, over 80% were symptomatic. Now, what slightly worried me was only 2/3 of patients had received any treatment for their COVID. So I don't know whether that means that people haven't been able to access outpatient treatment with antivirals and monoclonals, whether they didn't know they could access it. So I'm just going to spend a slide on that in a little bit, just talking about what you do if you do test positive. But what we can see here, although numbers are low, and please look at, you know, the hospitalisation rates and the death rates remain pretty low compared to the first wave. But those with no antibody response do seem much more vulnerable to hospitalisation and death just in this small group. So again, just trying to understand that we need to look after these patients more closely. So that's a bit on vaccination that Helen will expand on. So I just want to move now on to treatments and just really think about how far we've come. You know, in the spring of 2020, the only treatment we had for patients was oxygen. And we've then learned that we can treat the inflammation in the lungs, which causes the breathlessness, with just very simple steroids. We then started to get intravenous, so through a vein, antiviral drugs. And then we got these replacement antibodies called monoclonals, and we got better anti-inflammatories, tocilizumab and baricitinib. And so we found that when people were coming to hospital, they were doing much better than in that first very, very scary wave. And we've now shifted our treatment to try and prevent people coming from hospital. All those studies in the early days, the recovery trial, which the UK has done amazingly on, has shown us that earlier you treat patients, the less likely they are to have a severe outcome. So the government had rolled out through these medicine units or CMDUs, access to these monoclonal antibodies, these donated antibodies, and these oral antiviral tablets. And we've got new antiviral tablets literally coming out every few months at the moment. So that drug pipeline, which usually takes 10 to 20 years, has been incredibly rapidly accelerated. And it is making a difference. And actually, we're now moving towards thinking about preventative care. And that's where the pre-exposure prophylaxis with monoclonal antibodies come in. Now, as an immune deficiency doctor, I look after patients who don't have antibodies routinely. And one of the treatments we give them is IVIG, or normal human immunoglobulin. And we take blood from about 1,000 people, healthy people, and we take out all their antibodies and we pool it together. and we put it in a little bottle of immunoglobulin, and we give those antibodies. We donate those antibodies to people every month or so. And we know that that helps antibody deficiency patients. It reduces their infection rate and reduces their risk of pneumonia and hospitalisation. So the same premise is there for monoclonal antibodies. So because we don't have much COVID antibody in the immunoglobulin yet, what we want to do is use manufactured high concentration antibody against COVID in a very similar way. So what's happened? Well, I think we've got a number of studies now from the UK that show and evidence that these antivirals and monoclonals are improving outcomes in immune deficiency patients that have to go to hospital. Now, we're also developing data globally on whether these pre-exposure prophylaxis treatments are likely to work. No studies, well, the original studies focused on the general population, and we were then able to narrow down on some of the immune deficiency patients within that general population to see whether it made a difference. And that really helped us realize that actually we need to be doing studies specifically in patients that might have an immune problem. And there have been a number of studies about using the monoclonal antibodies as pre-exposure prophylaxis in the Delta wave, and showing that they're really quite successful in at-risk patients in preventing hospitalisation and death. And then we've just been having a discussion now that evidence base probably isn't all there for Omicron, but it's started to come, and I will mention that to you in a minute. So I just wanted to go back and just mention, what do you do if you test positive for COVID? I hope you all have access to some form of testing at home, be it with a lap flows, or some people may still have PCR tests. Now, many patients are on the list, but as I've found, not all my patients are on the list, no matter how hard, and lots of people have fallen through the gap. So I think communication and spreading the word here is really important. So if you do get positive and you register your test, you need to register that test. You should automatically get a phone call from one of these COVID medicine delivery units. And that should be within 24 hours of reporting a positive test. But we know that that doesn't happen. And so we've kind of set the scene for many of my patients, say, if you get COVID and you don't hear anything, please either call your GP, call 111, or call us. Because actually we may need to make a direct referral into that CMDU. Now, what a lot of patients don't realise is us in hospital, we're not allowed to give these antivirals, and we're not allowed to give these monoclonals. This has been delegated to the CMDUs. So what we have to do is refer to them, and then they will put your case through a multidisciplinary team meeting, and then they will contact you with the decision on whether you are eligible and whether a monoclonal antibody or an antiviral is most appropriate. Unfortunately, your treating doctors don't have that decision making at the moment to their disposal. So I encourage you, if you do feel unwell, please test. And if you do test, please register your test. And if you don't hear from someone within 24 hours, please escalate it and let somebody else know, because the treatments you are only eligible for them if they are started within 5 days of you getting your symptoms or a positive test. I don't know if you're as sick with this common learning to live with COVID or living with COVID. It seems to be a bit of a mantra at the moment that puts a number of our backs up. I kind of see where people are coming from, but we must all be included in this living with COVID. And some of for many of us, it's understanding whether immunocompromised patients remain vulnerable, and can we live with COVID in the same way that healthy individuals can live with COVID? And I think the short answer is it's not as straightforward. We know that vaccine effectiveness is less from what I've shown you and what Helen's going to show you. So vaccines, one, you don't make a stronger response necessarily, if you respond at all. The other thing that we see in immune deficiency patients is that that response wanes more quickly. So even in a healthy individual, the vaccine's only really lasting about 4 months. So I've seen a question saying, should we have the 4th vaccine? Should we have the 5th vaccine? Yes, okay, because you will need that constant topping up at the moment because their levels will wane. Unfortunately, as I've shown you, although things are much, much better, immune deficiency patients are still more likely to have severe disease. And then this also problem of persistent infection. And I've had patients that have been positive for up to 6 months, and it's been very difficult to clear the virus. Now, mostly this is patients with the most severe immune problems where they don't have B cells, they don't have antibodies, they don't have T cells. But it can be really quite a challenge in some patients to clear the virus. So do patients remain vulnerable? Yes, I believe they do. So this is where this idea of monoclonal antibodies as pre-exposure prophylaxis comes in. Now, what is a monoclonal antibody? It's an engineered antibody that targets SARS-CoV-2. And why do that? Because it gives a patient antibodies when they cannot produce their own. So in vaccination, you rely on the body's immune system to produce that antibody and that T cell response. And, you know, it can take 3 to 4 weeks to get a really good immune response, but with boosters, maybe more like 1 or 2 weeks. So there is a lag in time. And it probably lasts 4 to 6 months in most individuals, possibly less in immune deficiency patients. Now, monoclonal antibodies is what we call passive immunity or donated immunity. So we're just giving antibodies to someone. So we're not able to stimulate a T cell response or any other part of the immune system. And because we're giving those antibodies, they work straight away, which is why we use them very early in infection. Now, because these antibodies have been engineered, rather than lasting, you know, a few months, actually they're lasting potentially up to a year. So there is this opportunity to give much longer lasting antibody protection than with other antibodies. So a big question my patients are asking me, and I'm sure you are asking, is why don't we have access to monoclonal antibodies? There's been a lot of discussion about one of the products called Evusheld, but actually there are other monoclonal antibodies also licensed and available. Sotrovimab is one of the products that we already have in the UK. Now, what are the arguments? Why aren't we as clinicians able to start you gut all on treatment? Well, some of it is a battle of perception. And, you know, I'm sure you've all heard, as I've had, you know, COVID's over. Why do we need to be spending more money? We've just got to get over this. We've got to crack on. It's only a cold. All these mantras, I'm sure you've all heard. And actually that is, I'm sure, part of the influence of this. But actually, when they are taking advice, I think the government, and looking at the data, actually the data we have for how well these monoclonals work in patients is not strong, okay? So not strong in terms of we just don't have the studies and the evidence base to decide whether they are a good thing or a bad thing. So most of the evidence base for monoclonals came from Delta, well, from beginning of Alpha, but Delta mainly. And we could see from laboratory studies that many of the monoclonals weren't working as well in laboratory tests against Omicron than they were with Delta, okay? And there is some evidence that it's not necessarily preventing infection with Omicron, but all the evidence that I've seen is that in the big real life studies, these monoclonal antibodies do seem to be protecting against severe disease and hospitalisation and death. So I think there is growing evidence that these are the right things to do. And there is data coming out from America at the moment from observational studies looking at this real world data. And there's studies starting in the UK as well for both the Evershell product and the sotrovimab product to see how these antibodies are going to work in immune deficiency patients going forward. And I think the other big thing the government is struggling with is they don't know who should have these treatments and who will benefit most from them and how we identify those people. So this is, I think we all think that moving toward a preventative treatment is the right thing to do. What I wanted to just show you and share with you is the arguments that are being put up against using the monoclonals at the moment, even though they've been licensed and are being used in many other countries around the world. So, what's the future? I talked to you that many of the patients, many of the treatments are being given very strictly directed in these CMDUs. And I think over the next 6 months or so, much of this decision making is going to be given back to the NHS, and treatments will become more available to us as expert clinicians to be able to allow personalized decision making of your risk and what treatments are most appropriate. And that's where we were 2.5 years ago with pneumonias, and I think we will get back there reasonably soon, and I think that's a good thing. I think we will move towards pre-exposure prophylaxis. I think we've just got an uphill battle to get the evidence for the decision makers. I would encourage you all to check with your clinicians what studies may be open to you, and I think studies will be opening over the next few months to try and tackle some of these important questions around pre-exposure prophylaxis. And I think what we need to do is continue to manage the personal risk of COVID, and not just COVID, but all those other infections that people are vulnerable to. And this is just my kind of crib sheet that I talk through with my patients, just pragmatic stuff, and nothing you're going to do is risk-free. I said this to Nick at the beginning, even sitting at home isn't risk-free. A number of our patients, have maybe bacteria in their lungs at low level, and those can bubble over, So nothing is risk-free. But how do we reduce that risk to a level that we feel comfortable with? So certainly preventing infection with high quality masks, spending limited time in crowded spaces or indoor spaces. If you've got the option to meet people outside, that is going to be less risky than meeting people inside. And it's making those judgments not about what is risk-free, because nothing is risk-free, but what is lower risk. Try and avoid individuals are unwell. And this is so difficult for grandparents and for aunties and uncles and family members, especially when you've not seen your family for such a long time. But just try and avoid individuals are unwell. And if you are concerned, then again, minimize that risk by trying outdoor activities. Going back to work is hard, and those are difficult discussions, but speak to your workplace about your risk and try and get reasonable adjustment. I've written a number of letters for my patients, just explaining that they remain at risk, not just of COVID, but of all infections, and that these are reasonable adjustments to make. I would encourage you to get all the vaccinations you're eligible for, because more is better from all the evidence that we've seen. And not just that, to put a shield around you and encourage family members who are your greatest risk of infection to get vaccinated too. And please test if you have any symptoms. And, you know, potentially if family are visiting you, ask them to test. And please, please refer in if you get COVID so that you can start treatment early. I'm sorry if I've gone on a little bit, Nick, but I hope that there's some questions and that's generated some discussion and hopefully answered some questions as well.
Alex, thank you very much for a fantastic talk, and you've really gone to great levels to explain a lot. I learned a lot, and a lot was very clear. You have answered a lot of questions, which is really helpful, and it's going to be enduring content for everybody for the future as a recording. But you've also raised many questions, so thank you everybody for posting your questions, and please keep them coming. We're going to have a Q&A session after the second speaker, after Dr. Helen Parry's been able to give her update talk. And in the meantime, we've been collecting everybody's questions. Hopefully we'll have time at the end, and if not, we will follow up with you. So Helen, without further ado, the bar's been set high for you.
Yeah. Right, hopefully, can everyone see those slides? Is that working well?
Yep.
Yeah, lovely. Okay, so thanks, Nick, for asking me to come and give an update today. And thanks also to Leukaemia Care, who has supported this project right from the very start. And thank you to everybody who's taken part. I just had a quick look down the delegate list and I recognise so many names. I think I've spoken to so many of you over the last year since we've been running this study. So it's really nice that you're able to join this evening. So as you all know, I work in Birmingham and we've been running this CLL VR study, so CLL vaccine response study, really trying to get some real world data on the vaccine responses in patients with chronic lymphocytic leukemia in the UK. And we sort of took a different approach to perhaps other countries, and in terms of the vaccine program in the UK, we obviously had both the AstraZeneca vaccine at the start and also the Pfizer mRNA vaccine. And we thought this was also, you know, an important angle that we made sure we covered in the study. So we had 500 participants taking part, and 484 were also on this extended interval. So between the first dose and the second dose, you'll be aware that the government announced that they were going to extend the dose of the Pfizer mRNA vaccine to somewhere between 10 and 12 weeks between the first and second dose. And that differed again compared to other countries around the world that kept to the standard 3-week interval. So another sort of element that we wanted to make sure we were covering so that we had a good idea what the impact of that was for our patients. So we asked many of you to do dried blood spots if you lived outside the West Midlands, and that really gave us serological data. And what I mean by that is antibody response data. But with Alex, actually, we were also able to look at your total immunoglobulin levels, which were really, really helpful because we know that patients who have low immunoglobulin levels are often the patients who struggle to mount decent antibody responses. And then if patients lived within the West Midlands, which was roughly around 100 of the cohort, we actually went out to the house and asked if we could get a blood sample from them in their homes. And from that, we were able to not only get the antibody data, but we were also able to look in more detail at the cellular responses, so the other arm of the immune system, which I'm going to go on and talk about a bit more now. And for those patients who took part in the study, you'll know that we were on the phone for quite a while up front, trying to find out a lot about your infection history and whether you'd been hospitalized in the past with infections and what vaccinations you'd also had previously. So in terms of the sort of population overall, 53% were male, which is common for CLL. So it is a disease that's commoner in men than females. And the median age was 67, which is slightly younger actually than the median age at diagnosis, which is usually more around the early 70s. The median time between the first 2 doses of vaccine was 11 weeks, as per the government's recommendation. And then we've tried after each subsequent dose of vaccine to obtain the antibody data and Tcell blood sampling 2 to 3 weeks post vaccination. And we've kept that fairly consistent after each dose of vaccine. So in terms of when we looked at how long patients have been diagnosed for, on average, it was around 6 years, and more than 50% were on watch and wait. So they had never required any therapy and were on observation management. In terms of therapy, we had 99 patients taking part who were taking a Bruton tyrosine kinase inhibitor, 21 were on venetoclax, and 143 had had some form of chemotherapy in the past, plus or minus an anti-CD20. And by that, I mean things like rituximab or obinutuzumab. So this is really an overview of kind of where we started and where we have most recently analysed up until. So the first 2 doses obviously were either Pfizer-BioNTech, so the mRNA vaccine, or Oxford-AstraZeneca. And then the government announced a third primary dose of vaccine in around September time. And that was then at that point advised to be an mRNA vaccine. And that was really on the basis of the fact that by that point we had data in healthy populations that showed that the mRNA vaccines tended to generate a higher antibody response. So subsequent to that, 3 months later, we were all advised to recommend to patients to get a 4th dose, which was then considered the booster vaccination and the first booster vaccination. And many of you will have by now had your 5th dose of booster, which again was a subsequent 3 months later. And that again was an mRNA, was recommended to be mRNA. But obviously by this point, we've also got Moderna in our armory as well. So what we found, so looking at the antibody responses, this is first of all, so we have found that basically you increment with each dose of vaccine up until the 3rd dose. So after the 3rd dose, there seems to be a plateau in the response rate. Now, what we've analysed in this data is not the full cohort yet at dose 4, so I'm still awaiting to analyse the rest of the data, but this is around 170 the participants who I've analysed after the dose 4 there. And when I compare those 170 to the response they had after the 3rd dose, we see a very even response rate, dose 3 to dose 4. So we've basically reached a plateau in effect. And so that kind of makes us be able to sort of conclude now, I think, that we have around 20% of patients that are refractory to the vaccines in terms of generating an antibody response. And this probably is one of the most useful pieces of information, I think, as a clinician looking after patients with CLL, because they really are going to be, I think, our group where, you know, if we have to sort of advise on where perhaps we might look at using monoclonal antibodies, like Alex has alluded to, then actually that would be the group where you would consider it to be very, very important. In terms of when we look at who is in that kind of 20% group, really we are seeing that patients on the novel therapy, so the Bruton tyrosine kinase inhibitors in particular, often have a diminished response or no response at all. So when we looked at the whole cohort overall, if we just look at patients that have had no therapy and are on watch and wait, we actually saw 90% of patients there had a detectable antibody response. When we moved on to those on Bruton tyrosine kinase inhibitor after the 3rd dose, around 50% had managed to generate an antibody response. But the sort of quality of that antibody response and the magnitude of that response was reduced, compared to those on watch and wait. And then the BCL2 inhibitor patients, so that's patients taking venetoclax, this was around 69%, but the numbers here are much, much smaller, so not so confident in what we can conclude from that group. Patients who've been treated in the past who were clinically in remission seem to also have excellent responses, around 87% response rate there. So looking at the cohort overall and whether we could identify factors that would predict for these for patients who are unable to get antibody responses, here we found that those that were on Bruton tyrosine kinase treatment, so that's ibrutinib or acalabrutinib, those who were planned treatment, so an advanced stage at the point that they were vaccinated, and those with low serum immunoglobulins, so going back to the antibody testing that we did with Alex, that really defined the patients that seem to be most at risk of not generating an antibody response. And so when we looked at the magnitude of the responses, what we found is actually amongst those patients that are able to mount an antibody response to the vaccine, each dose of vaccine so far seems to be improving the antibody titer, so the magnitude of the response is going up with each dose of vaccine. I don't yet have this for fourth dose, but what we know from other studies is that obviously in the interim between us, if in the interim period antibody responses wane, so the next dose that comes along is anticipated to boost it up higher again, which is why it's important that you continue to have doses as and when they're recommended. One of the reasons, and I'll come on to the other reason shortly. The other thing that we found, and other studies have also shown in other blood cancers, if we boost, we also improve the quality of the response. So what we see when we look at neutralization assays is actually the antibodies seem to be able to function better and recognize the original Omicron virus much better with the subsequent doses of vaccine. So we then wanted to look whether the initial vaccine platform impacted on the antibody responses. And actually what we found between when we analysed after the second dose and when we analysed after the third dose, there was no difference between those patients that received the Oxford AstraZeneca vaccine and those that received the Pfizer vaccine. And that's in terms of the antibody response rate, so the proportion of patients who generated an antibody response, but also the magnitude of the response, so the titer, very similar between the two vaccines and no difference there after second or third dose. So this then brings us on to Omicron and sort of up to date to where we are now, but following third dose, this data was generated from. So here we've compared our control healthy age-matched population with patients with CLL in terms of their antibody functional response through neutralization. And what we've done is we've put the antibodies in the serum against the different variants and the original ancestral Wuhan virus. So when we look at Wuhan, which is the red dots there, we no longer see much of a difference between patients with CLL who can generate an antibody response after the third dose compared to healthy controls. When we looked at Delta, however, there's still this discrepancy. So there's almost like the functional quality of the antibody response isn't quite as good as those of healthy controls. And then when we look at Omicron, the blue dots, it drops dramatically, but actually is quite comparable to healthy controls. So when we looked at whether there was statistical difference, the only difference we saw was really with the Delta variant. And I think that reflects really what we're seeing also in the general population. We know that with Omicron, even vaccinated healthy controls without CLL are obviously still at risk of getting this variant. So that sort of, although we're seeing an improvement in the quality, particularly against the vaccine itself, because remember the vaccine is based on the original Wuhan still, when we look at the variants of concern that have arisen since, we're still seeing a reduction in the ability of our antibody response to recognize, if you like, the variants of concern. So this is the cellular response data now. So this is looking at the T-cell responses to the vaccine, which we haven't ever published until just recently. And we've looking two different methods. So we use what we call an ELISpot plate, and we also use an assay called quantiferon. And both of these look at a cytokine that is produced called interferon gamma. And cytokines are what we produce if we normally get infected. So they're the thing that our body produces that often makes us feel sort of like we've got chills and aches and not particularly well at the time of viral infections, but they're really important in our immune responses. And what we can do is we can stimulate the blood cells from the samples that patients have given us with the actual virus, so peptides from the virus, and then we look to see how well they can make these cytokines. And what we've seen is after the second to the third dose, we see a much improved response in terms of the ELISpot response to the T-cell immunity generated from the third dose of vaccine. And that's also been shown in other vaccine studies from other blood cancers too. So another reason why we think it's really important that patients are getting subsequent doses of vaccination here. And then what we've also done is compared whether patients who had the original AstraZeneca vaccine had any difference in their T-cell responses compared to the mRNA vaccines. And the reason we were interested in this is because it has been shown in certain studies with healthy donors. And we've also, so here we did see again with the ELISpot and with the quantiferon a difference between the second dose for ELISpot and for the third dose for quantiferon, with those that had the Oxford AstraZeneca vaccine having higher interferon gamma responses, so higher T-cell responses. The one thing I was going to say as well is this data has also now, this sort of finding, if you like, has also now been shown with patients with myeloma. So in the PREPARE study, they've also seen this sort of difference. And then Sian Lim's study, Prosecco, down in Southampton, has also seen, and that's looking at mainly B-cell lymphoma patients. So there does seem to be something with the ChAdOx vaccine, the AstraZeneca vaccine, that perhaps it does seem to be able to stimulate improved T-cell immunity. So this is what we were really chuffed about. We have compared the original Wuhan peptides to the Omicron peptides and how well they are able to stimulate the T-cell responses in patients that are vaccinated. And I should have said, none of these patients that we've tested have had any evidence of natural infection. And we were able to show here that in patients that have been vaccinated, the responses are equivalent for the T-cell responses to Omicron and Wuhan. So this was really important because obviously the data I showed you with the antibody responses is perhaps we see this discrepancy with the variants of concern, whereas actually the T cells seem to be able to give very good cross protection against the variants of concern. And I've just stuck a picture there so that you can see this is the actual plate reading that I'll get in the lab, where the spots represent the interferon gamma being detected basically after we've stimulated them overnight with the peptides. So this is the sort of clinical observational side of our study, and there are obviously 500 patients, so a good, that have CLL, so a good proportion of patients here for follow-up study, and obviously everybody was recruited at the point that they had had a dose of vaccine. So we were able to look really at what the breakthrough infection rate is in patients with CLL, and obviously over the past year we've gone from, as Alex pointed out, patients shielding, and now as that's lifted, more and more people socializing and mixing again. So we found that there were only 2 deaths on the cohort, and both of those actually were due to secondary malignancy, so not COVID related. We've had 7 withdrawals and 5 were lost to follow-up, but we were able to confirm that they were alive. 78 cases of COVID-19 were reported, and we could see that there are an additional 8 donors that have had evidence of natural infection by the antibody testing that we do. So overall, we think 18% of the cohort now has had an episode of infection with COVID. Of these, 66% were breakthrough cases. So 14% of the cohort have had a breakthrough infection since having a single dose of vaccine. When we look back, the lowest rates were during the alpha wave, only 5, but obviously this was at a time when everyone was shielding still. Of those, 20% needed to come in. Actually, it was only one out of the 5. Then when we go to the delta wave period, 22 of those cases occurred during the delta wave, and 32% needed to come into hospital at that point. Then since December, we've had 39 cases. So the vast majority have all happened literally in the last 3 months. But of those, only 3 required admission into hospital. So we assumed at this point that actually it may well be due to the fact that by now we had access to monoclonal antibody therapy and antivirals on when patients tested positive. However, when we went on to find out whether there was a history of that, actually only 36% had accessed and received outpatient therapy. Of those 36% though, none had required admission. So again, sort of a really important point to make sure that people are accessing the CMDUs to get treatment if they test positive for COVID-19. So this took us by surprise. So this is looking at whether if you have an antibody response, whether that is protecting you against infection. And Alex has already said, I mean, huge population studies have taken place now looking to see if we can predict or come up with a correlate of protection that we know if you have a set antibody response, you're not likely to get COVID. But that hasn't been the case, and there isn't sort of a defined cutoff. But you might anticipate that perhaps if you're somebody who's able to generate an antibody response, you might be less likely to get infection. But actually, we found the opposite. So we actually found that patients who had an antibody response actually seemed to have an increased risk of infection. So we then drilled down on that to try and find out if we could predict any factors for those that were testing positive for infection in the cohort. And actually, it seemed to be those that were younger that were independently predicting for infection. And we think this is most likely to reflect the fact that they were probably social mixing more, returning to work, and the behaviour probably reflects the fact that they then were coming across infection, the COVID-19 infection, and becoming infected. So in summary, antibody responses we've shown improve with the third dose, but they then seem to plateau, and we have a fifth of patients who really still do not generate an antibody response. And I think this is likely to continue going forward, regardless of the number of vaccine doses that patients get. These seem to be patients, particularly that are on BTKI therapy or have known low immunoglobulin levels, so hypogammaglobulinemia. And we think these patients are really the ones going forward that are obviously at risk, but also at risk of reinfection as well. And we do have a series of patients on the study now that have actually subsequently been reinfected again with a second episode of COVID. The neutralization amongst responders is diminished against the Omicron variant, and the risk of infection obviously is remaining high. Cellular immunity, though, does seem to give very good cross protection for Omicron. I think this is a really important point to take away, and the stress on patients who think, oh, I'm not generating an antibody response to vaccine, but actually there's so much more immunity gained from a vaccine than just the antibody response. So please do continue to get additional doses. The hospitalisation results encouragingly are reduced, and Alex has already talked about generally in the population of secondary immunodeficiency, how much reduced they are compared to the beginning. And I think, as Alex alluded to, we have seen populations and countries where the vaccination uptake has been poor and Omicron has ripped through it. So I do think we have, to take heart now that the vaccines are doing good for patients with immunocompromised blood cancer conditions. And then finally, please be aware of the CMDU and access monoclonal antibodies and antiviral therapy as soon as you test positive. As Alex said as well, we only have 5 days to get these drugs delivered to patients after testing positive. So it's really important that we're on the ball and moving fast at the point that anybody gets tested positive. And just some acknowledgements there. Thanks again to everybody who's taken part. Really could not have done it without any of you. And again, thank you to Leukaemia Care and the other blood cancer charities who have really supported throughout. And just to the funders there at the bottom, so the UKRI, National Core Studies, and NHR. Thank you.
Thank you, Helen. Really encouraging data, and be interested to see how that also translates into other blood cancers. But I'm sure that everybody who's listening, there are quite a few questions that have been raised from that. But what I wanted to do, if we could sort of go back earlier to some of the earlier talks around vaccinations, there's a few points that have popped up. And I was looking around questions with regards, we're talking at the moment about, we're on the 5th vaccination. So I've got a fairly straightforward question. Are we likely to have regular continued vaccinations in the immune compromised population? Is this something that will continue? Something that has also been raised, I'm going to add a few questions together for you fairly quickly in this area. Family members and boosters. Alex, you talked about making sure that you created some local herd immunity by wrapping yourself with family members that are less, that are protected. So there's questions here about, can family and members access boosters? And there was a similar question in this at the moment around, does it matter what the mix of vaccines are? You've alluded to mRNA, get it right, mRNA vaccines being what are currently in use. I'm assuming those are now what are being currently used. So those are sort of three initial questions. I'm just wondering if you, Helen and Alex, would like to pick those up. I don't know if one of them's a policy question, but
I think in terms of vaccines, there's likely to remain a vaccine policy for the next year. I would imagine we've got at least one more round, if not more, of vaccines to go. And I think people are planning towards autumn boosters and very much hoping that we will get to the autumn and people will have their flu vaccine and their COVID vaccine. Now, there are vaccines out there against different variants, which are being tested. But the feeling at the moment is that we're constantly variant testing, and that those variant vaccines aren't producing any wider immunity against other vaccines than the original strains. So people are talking about mixed variant vaccines, but I think the problem we have at the moment is that the virus is still mutating at such a high rate that we are chasing these variants. And I think that probably will calm down when I speak to my virology colleagues, but we're kind of just not quite there yet. So I think we will have vaccines. I think there is reasonable evidence that playing pick and mix with your vaccines has been quite successful. We call that heterologous vaccination, so mixing the type of vaccines. And certainly the best immunity that we see, certainly in the laboratory, is when people have had natural infection and vaccination. That is, you get really good levels. But obviously, I don't advocate you guys going out getting infection. That would be bad. In terms of family policy, it can be very difficult. I know I've had, obviously, if you've got partners who are of an age that fit into the standard policy, that works quite well. Sometimes we've managed to get family members vaccinated who are younger, but it seems, I think you just need to work with your GPs to say, I'm vulnerable, I haven't produced any response, can we get so-and-so vaccinated? And we have had some success there. Helen, I don't know if you've had much success with family members.
Yeah, we've actually written it into the guidelines as well, the UK guidelines, to try and advocate that all family members get boosters over the foreseeable.
Thank you, Helen. Ella, have you got any comments in that area?
Not really. Just other than as it stands currently, the policy is that unfortunately, family and household contacts can't get the spring booster unless, as Alex said, they're of the age that naturally fits into that cohort. But yeah, I think an autumn campaign can be expected, and that may be wider than what this spring booster campaign has been.
Thank you for that. And so in the interim, contact your haematology team, see if they can press some leverage on that basis, is what I'm getting from this. There is a question that was concerning me, just from a question of correctness with guidance. The 5th vaccine, between 4th and 5th, is that meant to be a 6-month or a 3-month gap? Ella? Yeah,
good question. This was really confusing, and I think still is. So essentially what I think is that the government have said that they are trying to get everyone onto a similar time frame so that for future campaigns everyone sort of lines up and it works quite well. So for that reason, I think it's between 3 and 6 months. So that means that many people will be invited for their spring booster at the 3-month mark, but some might not be, and people are saying up until 6 months. So within that time period, that's when you can expect to hear. If you haven't heard after 6 months, then that's an issue. But something I would suggest is you can also try, if it has been 3 months and you haven't sort of received an invitation automatically, you can try on the NHS booking vaccination site and see if you can book a vaccine. You may be able to that way without an invitation, but don't panic too much if it's still not been the 6-month mark, because I do think that they're somehow trying to align everyone. So that's the reasoning behind it.
Thank you for that, Ella. And I just noticed somebody posted there about advice for GPs. Is anything enforceable? I guess our advice on that is if you're having a problem, talk to your haematology team or to Leukaemia Care Advocacy, who might be able to advocate on your behalf to communicate with you for your GP practice. Is that what you would concur with? Yeah. Straightforward or not straightforward question. Important again. This is a really big one. Who should have the 5th dose? How is that? I think that question came from, is that everybody who has a blood cancer? I think it also came from Watch and Wait. Somebody was on Watch and Wait asking, should Watch and Wait people have the 5th dose, the spring dose? My understanding is yes, but I really probably we want to hear from you guys. Is that
so? It's
an answer?
So it's adults over age 75 and over, or residents of a care home for older adults. It's also all individuals aged 12 and over who are considered immunosuppressed. So that does include most people with leukemia, as Alex mentioned at the start of her presentation, if the leukemia itself has caused an immunosuppression or indeed the treatments that you may be on. But if you're not sure whether you are immunosuppressed, please do speak to clinicians, doctors, GP. That's what I would say.
Just following up on that, Helen and myself looked at the immune deficiency associated with CLL watch and wait patients a few years ago, didn't we, Helen? And probably over a third of patients on watch and wait for CLL have a reasonably significant immune deficiency already, just from the blood cancer. So this is where I get into fights with Helen over coffee, and I say that these are actually my immune deficiency patients, not her hematology patients. So we're fighting over you.
Not literally.
Well, it's great to have both of you on the side of the patient. There's 2 arrows in the bow. Yeah.
I think we need to make sure that the idea of watch and wait doesn't mean that there is absolutely wrong.
Yeah. And also, we've shown time and time again that actually getting vaccinated early in the disease course is the best thing you can do. So particularly for flu, for pneumococcal, the earlier you get vaccinated, having had a diagnosis of CLL, the better the immune response.
Thank you, everybody on that. I'm mindful of time. We're getting quite low, so we have a raft of questions, and I think we're going to have to address a lot afterwards, Ella, between us as a charity to reach everybody. And maybe if we don't reach them all, if we have any questions, maybe we could ask yourselves, Helen and Alex, after, if you could help us with some responses if we emailed you. I'm just going to run through a few. There's one that has come up, priority PCR tests versus LFTs. Should people still be using PCR test kits as a priority, or are they now to use LFTs? Do we have clarity on this? Somebody's asked this question.
So I think they said, yeah, so the priority PCR kits aren't irrelevant. You can still use them, and they are a way to get the access to the antivirals or start that process rolling. But you can now also use lateral flow tests. And I think if you've got access to the lateral flow tests, it is likely to generate, I think, a slightly quicker response than sending the PCR kit off. So either works, whether you have one or you don't, but I would be inclined to use lateral flows if you've got access to them. I don't know if, Alex, you have anything to comment on that, or Helen?
Yes, so I would do both. Yeah,
we're
struggling to get treatment, and it's about quick turnaround. The problem with lateral flows is they are less sensitive than PCR. So they may well not pick up your COVID if you are early in the disease or you've got a low viral load. We know that they are only, maybe 40–50% as sensitive as PCR tests. So do your lat flow. If that's positive, all well and good, get it registered, get in. Time is of the essence. But if it is negative and you've got symptoms that you think is suggestive of COVID, get that PCR test done as well. So at least it is cooking. You know, I've known patients on lateral flows that have been, you know, negative and then 4 hours later positive. So it's that repeat testing is also useful. Not everyone now has access to PCRs. So actually a key tool of our trade now is the lateral flows. So what I would do is not do one test and then leave it at that and say it's negative. We know the sensitivity of lateral flows goes up with frequent testing because the virus increases in number, and the higher the viral load is, the more likely you are to be positive. The other thing is, guys, don't swab your ear. You know, it doesn't work. It's got to be a really good swab. And I know that sounds a bit silly to say.
And that's still nose and throat together.
Absolutely. So I think the nose is much less sensitive than throat. So I would get a really big, you know, sweep round the back of your tonsils and up both noses. What I find in my immune deficiency patients is actually we're more likely to get the virus if we can't find it on sputum, so on stuff that's being produced, than in the nose. So that just goes to show the lower airway is where we might get the virus. So do a good swab, and if it's negative, do it again 12 hours later.
Thank you, Alex. That's actually answered some very interesting questions. So from that point of view, there will be people in the audience that have a priority PCR kit that they were given, and they will now also probably have LFTs. It's something that I've always often thought about. Feeling symptoms, how do you balance? When do you go for the PCR test if you've got that one PCR test? If those symptoms are lingering, and you can get yourself to somewhere where you can be PCR tested, you would advise that, because the LFT might not be picking it up.
Possibly, but just keep testing. I mean, the other thing is there are a lot of other viruses out there at the moment. So
this is a problem for immune compromised patients. We pick everything up, and we've constantly got a sore throat, constantly got a chest infection, constantly got a headache.
Look at the emergency department. There's lots of flu at the moment, flu A, and there's also lots of different respiratory viruses. So, you know, I think you can do your best. So if you have symptoms that you just think are worse than usual, then use your PCR test. But actually, frequent lateral flow testing does increase the sensitivity.
Thank you very much for that. We have so many questions. We're not going to get to them all. I think one of them that was really interesting was listening to many questions around challenges that people have to access their MABs or monoclonals or antivirals should they have infection. And somebody even made this counterintuitive message that you're on a priority list, but that doesn't mean you're entitled. Is there a criteria for accessing antivirals and monoclonals that patients should be aware of, that can be used? Because obviously we're getting a lot of messages from patients that have tested positive, they're on a priority list, trying to jump through hoops because they believe that people believe they should have access to the treatments, but are not getting them. So the question has come up: is there a criteria there, or is it the MDT makes a decision on a one-to-one basis?
Yeah, so it is subject to a clinical assessment. I don't know the details of that clinical assessment or whether it's publicly available, but essentially they don't want to give antivirals to people who don't need them. So if you are immunocompromised and you have got COVID, the clinical assessment is to determine whether the antivirals would actually prevent you from serious illness, or whether you might not actually get that anyway. And so it's not guaranteed that everyone on the eligibility list will get the antivirals by default. Like I said, I don't know exactly what's included in that clinical assessment, but they will also be looking at symptoms and things like that, I believe.
So Ella, there is commissioning guidelines for this.
Are they publicly available?
NHS England, which patients are available. And I don't know where they are off the top of my head, but that's how the MDTs make the decisions.
Yeah, so there's an eligibility criteria, which I'm familiar with, but but I'm talking about post being on the eligibility criteria, then patients are subject to additional clinical assessment to determine whether they should or should not receive the antivirals.
I'm quite surprised because I mean, an experience from just clinic, most patients that we know are aware that they've got an immunocompromised condition. We haven't, I don't think, had anyone turned away or refused monoclonal. Alex, have you?
I haven't.
No.
So every case that I've put forward has been accepted.
Yeah.
There isn't further clinical assessment. What the CMDUs are doing is making sure that they meet the eligibility criteria.
So I think this might be coming from the automated system. When you're logging your LFT online, you get your call back in an hour, in a day, through that process before there's been any contact with the haematologist where you're making that referral. So would you advise that in those instances, if people are on the priority list, they've registered and they're having to jump through hoops, that they should be in contact with the haematology team at the same time? Is that something you would advise?
GPs are helpful 111. We've directly got patients through on the 111 referral system, but also the haematology teams. So, if you've got a great relationship with the GP, they might, do that for you. So, it's worth just trying everything.
Thank you very much. I'm mindful that we're not going to get many questions in. There's a couple that would probably, I think a broad question is how can patients understand their level of their own vulnerability? There's been a lot of people asking questions around accessing antibody tests, and then you've given your fantastic talks that have also showed that cellular immunity and T-cell responses is of equal importance. But you also pointed out that patients who are immune compromised have lived in the past pre-COVID, maybe some haven't if they've been diagnosed at the time. What is the best way for patients to try and understand or get information that gives them an indication of their level of vulnerability from an immune compromised point of view? As clinicians, is there any way that you can give advice in that area?
So I would say one of the things that came out from this study was actually patients that have a history of significant infections that have needed to take them to hospital or recurrent infections seem to also be those that didn't mount particularly good antibody responses initially anyway to the first two vaccines. So I think if you are somebody who has a history of serious infections or recurrent infections, that in itself tells you are a patient probably at higher risk. Just inherently, you are probably somebody who actually, if they get COVID, really need to be getting to that CMDU ASAP. I think in terms of accessing antibody and T-cell tests, the T-cell testing is difficult, and it's not particularly done outside of really a research setting. There are companies that are trying to set that up, and going forward that may change, but currently it's not really something that would routinely be done in a hospital setting or in a clinical setting, full stop, really.
Okay. So it's a question, if you've got history, listen to your body and bring that into account. How does that help? I guess I'm trying to attach that to the point of view of mitigating your risks. That was something you talked about quite at length, Alex, in your original talk, encouraging people to take on, make sure you maintain your, your protective measures. I guess that's also much a part then, in terms of how do people set their bar of risk when they're navigating in this current climate at the moment, with there being very little rules within the general population? Have you got any thoughts on that?
Nick, I think much more, there's no bar, but there is a sliding scale. Okay, a bit like I said, there's no protective antibody level. There is a sliding scale of risk. Now, if you had a new grandchild and you wanted to see that grandchild, I think you would probably want to take the risk of going to see your family almost regardless in that situation. You know what I mean? So it's about identifying what is important to you as an individual.
There's risk benefit.
With risk benefit.
Yeah.
And those are the discussions that I have with my patients every day, is if this is important to you, then mitigate the risk as best you can, but be aware that not doing it may do you more damage than doing it. Given that we've got such good outcomes at the moment, it is just that ability to take small steps. And I just really encourage people, it has been and it still is a very difficult time for so many immune suppressed patients. But the only way to start back is with small steps, and it's got to be what you feel comfortable with. I would very much hope that none of you guys are going night clubbing at the moment. That would not be on my agenda. Whereas, maybe, starting to go to the shops, but early in the morning or away from the busy crowds, or, maybe, just starting to do some of your activities that you used to do, meeting people, say for a coffee. But, if you can meet outside if it's not raining, why not? So it's about mitigating on that sliding scale rather than where that bar is, Nick.
Thank you. That's the most helpful, a very good way to end some of the discussion. I'm going to just pass over one last question and ask Ella afterwards as if you have any comments. One thing that's piqued my interest is questions about talking to your clinicians about studies that may be available for pre-exposure prophylaxis. Are there any now that are live that you are able to mention, Helen? Because obviously that might be a route to access that patients can take in the interim.
So currently, none that I'm aware of are actively live. We have 2 in the UK shortly to open. I think one's hopefully opening around June time. So that's going to be called Protect V. And then around a similar time, there'll also be an AstraZeneca study coming out as well. I haven't heard actually when that's starting, but that will be the other option for getting access to prophylactic monoclonal antibody.
And the inclusion criteria for those, do you know?
So they are specifically both trying to recruit immunocompromised patients. Alex, you might know more on Protect V, I think, because you're on the...
So what they're going to try and do is produce not patients that have made no response, they will all be included, but they also want to include patients that have made a low response to vaccination. So a number of the leukemia patients will have made a low antibody response. But for both studies, I understand there's going to be screening, and that's going to be based on your antibody response. So if you've made a cracking antibody level, actually you don't need monoclonals really, because your immune system is competent enough to deal not just with the vaccination, but probably with other infections as well, in a reasonably safe way. So, we use vaccination clinic as a marker of your immune function and how your T cells produce to your B cells. And it's a surrogate marker for me of how you're going to respond to infection. So yes, people who have no and low antibodies are likely to be eligible for both those, and both studies I believe are open for blood cancer patients.
Thank you very much. And from our side as Leukemia Care, we'll keep in touch with the clinical community to make sure that information is available to everybody. Ella, a parting shot. Do you have a last comment before I put up some slides?
The pressure.
Well, we have many questions, I guess, from the point of advocacy, how we would look to be able to respond and field.
Yeah, I would just encourage people to email our advocacy team with your individual questions. We will be able to answer them. Just unfortunately, we run out of time today. But yeah, if you do have any questions that haven't been answered, feel free to email the advocacy. I'll pop it in the chat again. Or Nick can pop it on the slides. I think it's coming up.
I think I'm just about there with a few slides. If I can get the Starship Enterprise to work for me. There we go. Thank you everybody again for joining us today. And I really must thank our esteemed panel. Fantastic information. I'm definitely going to view it a few times because you've covered a lot of ground on the slides, as well as your very eloquent and meaningful ways of explaining it in an understandable way. So some service available from Leukemia Care, if I was just to run through a few things there. Obviously, we provide, for those that don't know Leukemia Care or even do, information sources, regular webinars. I'll touch on the next webinar in a short while. The newsletters and magazine. The quarterly magazine is just been printed within the last few months, and there's regular updates, newsletters that will come to you automatically. So please do contact the website to offer your permissions. Regular podcasts, social media, and the website is frequently updated. And Ella, who is on the panel here, is one of our great writers who's constantly updating the blogs for us. On that note, we do hold a COVID information hub page on the website that covers a broad range of up-to-date information that Ella and team keep as up-to-date as possible, and something we've been kept very busy during COVID. I touched on Leukemia Matters. Please do subscribe to the magazine, pop onto the website, well worth a read. It gives you good up-to-date information, lots of patient stories and ways to engage together. Next webinar, 3:30, Thursday the 28th. What can help when talking to others about your diagnosis? Probably more relevant today than it would be with, if you've been diagnosed, we know how hard it is to talk to other patients, to other people, family, friends, employers, everybody. COVID's now added another spanner in the works. So how do you talk to people about being immune compromised? How do you talk to people about navigating it? So it'd be well worth a visit. And this webinar will be supported by the supportive care teams, the clinical nurse specialists, and experienced patients in different indications to share their experiences in that area. So I would recommend joining that webinar. Support services offered by Leukaemia Care, helpline and WhatsApp. We have a clinical nurse specialist available 5 days a week on the helpline, and the support services team are always there for you. And we offer a WhatsApp service for immediate response communications. Virtual support groups. The charity provides a national network of support groups, both topic specific, local, and also national groups. So we've got quite a network there. If you're not, we haven't been able to join support groups in person, but we've got a great virtual support group network. Have a look on the website. You can see there's something there that might fit you. We have a welfare officer. So we offer welfare advice, which is obviously very current in today's climate. So if you're feeling the pinch, get in touch with advocacy, get in touch with our welfare department. And again, advocacy support, Ella and team, the rest of our team are there for you if you need any assistance or any help with any issues that you have. We're offering online forums, Facebook groups, very busy. Something that's a great help to many is a buddy scheme. If you're always in need of it's a eureka moment when you meet your first patient if you're diagnosed as a patient, and it's really handy sometimes to have contact with somebody else that's living with the same condition who gets it. So buddy schemes are something I'd recommend to everybody. We also offer a counselling fund that you can apply to for Leukemia Care through Leukemia Care. I think that, if I'm right, Ella, that offers 6 counselling sessions. I'm not sure if there's a waiting list at the moment, but it's something that's open to everybody diagnosed. Is that family as well, Ella?
I believe so, yeah. The full details of the application and things are on the website. Excellent.
Advocacy caseworker, I've just discussed. I'll skim through the slides. The Anne Ashley Counselling Fund I've just talked about. And yeah, it's hard for everybody in the current climate. So if you're inclined to help with fundraising, there are many different ways you can do that. I think we've got a new campaign coming up, Run 50 for the 50,000 people living with leukemia. And I think there's no set goal on what you have to raise. And I think my understanding of this, I haven't quite got it right yet because it's a new campaign, but I think it's covering 50 miles in a period of time, running, walking, jogging, and raising a little bit of money to help support the charity so we can offer services to you. And if you're adrenaline junkies, there are always some great things like skydives and zip wires. If you're that way inclined, these are areas that you can help. But the fundraising activities are always there on the website, and we can all do with your help. So keep in touch with latest news and patient stories. So we've got our social media platforms, Facebook, Instagram, and Twitter. Comms, who are also supporting us here, are massively busy, really creative, lots of information always available. So if you're social media people, do follow us. And I'll just end here before thanking everybody. Here's our free phone helpline. So if you should need anything at any time, just get in touch, or you can alternatively email us at support@leukemiacare.org.uk. So I'd like to thank everybody again for spending time and joining us this evening. It's been fantastic to have so many of you with us. And I'd like to again finish by thanking our fantastic doctors, and Ella, you've always there doing a great job. Thank you for joining us as well. Thank you, everybody, and good night.